We are live.
Thank you. Good morning, everybody, and welcome to the Board of Health online viewers to the March 5 Board of Health meeting on this rainy and cloudy day. The board meeting is officially called to order at 8 a.m. This virtual meeting is being streamed via Facebook and will also be rebroadcast on Facebook and YouTube. The February Board of Health minutes were distributed to the board for the review prior to the meeting. Are there any discussions or amendments to the minutes? If none, do we have any motions to approve the minutes as dispensed? We have Ms. Margoli.
Second.
Second. Thank you very much. All in favor, please raise your hand. Thank you. Any opposed? Please raise your hand. Any abstentions? We have none, so motion is approved as distributed. Thank you very much. As a part of the chair business for today, I just want to bring attention to what's happening in the south part of the country. The Texas Department of State Health Services updated the number of people with confirmed measles diagnosis yesterday, March 4th, and now we have 159 patients. Most of the cases are unvaccinated or with unknown status. 22 of these 159 have been hospitalized, and the majority of these patients are between 5 to 17-year-old kids. So this is a call to our community and to everybody who watches this Board of Health meeting. Let's remember that measles is an infectious disease caused by a virus, and it's preventable. We have MMR vaccine that is safe, that is efficacious, and please do vaccinate your kids. If you have any doubts about being vaccinated or about being exposed, ask your health provider, and you can always request an extra booster just in case. This morning, for our perspective session, we will have the Green Heart Louisville project, and the presenter will be Dr. Theodore R. Smith, who is currently with the University of Louisville and who has a distinguished background in both research and civic innovation. Dr. Smith holds a Ph.D. in experimental psychology from Miami University and completed a postdoctoral fellowship at the Massachusetts Institute of Technology. Dr. Smith's research is primarily focused on environmental determinants of health, of disease in urban and urban environments, with particular interest in health research, models, and methods, with a breadth of experience spanning academic, civic, and private sectors. Dr. Smith's work often bridges academia and local governments, utilizing new technologies in community engagement projects. He has a specific focus on environmental clinical monitoring, including digital health surveillance for respiratory disease related to air pollution. Dr. Smith served as the Louisville's first Chief Innovation Officer, where he led place-based health projects like the Air Louisville Exposure Study, which led the groundwork for the Green Heart Louisville project. His recent research includes wastewater monitoring to assess disease risks in the city's correction system and senior living centers. Post-pandemic, his work has expanded to include wastewater screening for non-communicable diseases linked to exposure to volatile organic compounds and PFAS chemicals. Today, Dr. Smith shares his expertise on environmental health, public health innovations, and community-driven research with the Louisville Board of Health. In June, we hosted him when he came and talked to us about food is medicine. Today, I present to you Dr. Ted Smith. Welcome, Dr. Smith. If you have your presentation, and you would like to share, you may do so at this time. Thank you.
Thank you, Madam
The floor
Chair.
is yours.
I really appreciate the invitation back. I know you've got the junior varsity team here today. You wanted Dr. Botnager, but unfortunately, we are all a little overbooked here. So I hope you'll indulge me, and I'll do my best to channel him. Just as a reminder, I'd love it, since I also didn't get the agenda for the board meeting. How much time do you want me to talk? Because I'm prepared to do this in 5 or 55 minutes. What's your preference?
You have 20 minutes. You have 20 minutes with 10 minutes for questions and discussion. Thank you so much.
All right, thank you. Thank you. All right, let's see if I can get this thing shared. Okay, are you able to see that? Very good. Well, great. Again, thank you so much for the invitation. It's always great to be with the Board of Health, and thank you for all you do for our community. It's obviously critically important work, and more important every day, apparently. For many of you, this might be a review, and for some of you, maybe this is news. So I'll try to do my best to balance doing this quickly, but try not to assume you already know much about it. Our work here, let's see if I can make this move. Our work here is really predicated under the idea and the notion that increasing greenness or vegetation, and just to be clear, that's not just trees, that's greenness. Now, one of the most efficacious ways to deliver a lot of greenness into a community is to put a tree in the ground, but it's certainly not the only way, and it is probably not best done all by itself. So greenness is really the topic. For many, hearing that bringing nature into cities or bringing nature nearby people is an intuitive and welcome thing, because I think we also recognize that there are broader environmental effects of doing that are also good and desirable, well beyond whatever health benefits may be presented. And so we do know there's a wide range of environmental effects, and a lot of times we'll call those ecological system services, stormwater runoff, noise, increase in biodiversity, light management, all these wonderful things that, bringing nature can bring sustainably into an ecology. But we also know that there are social effects, and of course, Louisville is famous for its commitment to park systems and kind of understanding the power of bringing people together in outdoor spaces, the redevelopment of the waterfront, now the Belvedere. So there's a real, I think, deep understanding here that there are social benefits for doing this work. But our focus, of course, here at the University of Louisville School of Medicine is on health, and there is ample cross-sectional associative evidence that there are all sorts of wonderful health effects of bringing greenness into places. So let's see if we can. I'm just struggling with advancing. I'll get it. So I think at last count, there's 180 peer-reviewed studies that show a health benefit, whether that's a physical health benefit or a mental health benefit of proximity to green spaces. And interestingly, because a lot of our work uses the cardiovascular system as our primary readout, there's tremendous evidence that the cardiovascular system specifically has strong associations with time spent in nature or near nature. One of the more sort of fascinating studies published, kind of 10 years ago now, was as the emerald ash borer infested North America, and it moved, south from Canada. As it moved through communities over time, cardiovascular mortality increased. And we lost, I don't know what the last number was, 100 million trees. I mean, there's a lot of damage from that pest. But it is interesting that, there is this association that when trees die, people die. And so it gives us a little more kind of motivation to take this very seriously, that there could be some important clinical benefits. So to pursue that, we created a project to essentially prove it. I mean, one of the issues with these associative studies, as I'm sure you all know, is while we can demonstrate there's a correlation between these things, we don't have the full comfort that we understand the causal pathway. And there are any number of reasons. I'll touch on a few of them today to imagine that greenness could be acting through, could be a kind of a mediator of a process that's some other process. For example, if I go spend time outdoors walking in a park, the cardiovascular benefits of exercise are significant, right? So we don't want to get confused that greenness is causing good health if we haven't truly established what the pathway looks like. And so we did create this project to do that, to bring a higher level of evidence to the discussion. There are very few, in fact, no large-scale interventional trials in this area. And for good reason. It's really expensive to do this kind of work. And it's also sort of not necessarily within the boundaries of traditional work that NIH or any other health research agency would fund. And so much of the heavy lifting here was actually arranging a partnership. And in this case, the primary actors in this partnership are the National Institutes of Health and the Nature Conservancy. And we can talk a little bit more about that in a second. We've had quite a few other partners involved. This is very transdisciplinary work. There's a lot that we don't know about environmental science. There's a lot that we don't know about tree biology and plant communities and birds and other things that we've had to sort of get our arms around in order to do this work. And so we've had a wonderful collection of partners for this whole project. Central hypothesis of the project is that exposure to neighborhood greenery diminishes the risk of cardiovascular disease by decreasing levels of air pollution. While we could have picked any number of factors that greenness can confer that could be of health benefit, very difficult to get through an NIH study section without a very concrete mechanism, to justify the investment. And so there's an abundant literature on air pollution and cardiovascular disease. Much of that has come from our team at the University of Louisville, going all the way back into tobacco research. So once we figured out that smoking cigarettes causes heart disease, you move right into air pollution. It's all the same mechanisms, the same kinds of damage and repair that's involved. So we had the credentials to essentially say, well, we're going to work on reducing cardiovascular disease risk by removing air pollution with vegetation. And so that was seen as a valuable idea. And so we went through a long process of identifying a place we could do this work. I think one of the things that a lot of people might not appreciate about this project is it's a community-based interventional clinical trial. And many clinical studies, don't have the requirement that you're, negotiating with neighborhoods and community groups, because most clinical trials are private matters. People go to clinical sites. You don't know who's in a trial. That's sort of the way it works. But that's not the way it works in environmental medicine, where we need to research people in places. And so a really important part of this project was finding a collection of neighborhoods that would be willing to be part of a research project where we would be increasing the vegetation in their community pretty significantly. And so we were able to, and we had other requirements, where we needed a source of air pollution. We needed, an opportunity to add greenness to areas. So we also needed to think about who was in these communities. You don't want to be it's sort of a Goldilocks problem. You don't want to be in an over-resourced community where it's probably primarily white and primarily healthy, with not a lot of opportunity. You also don't want to be in a place where there's a lot of transient population. So high renter communities are really hard for longitudinal clinical studies, right? Because there's churn in the neighborhood. You can't do the study. And then there are a vast number of other health challenges in places like that. Might be very difficult to see a health effect when there are so many factors that are conspiring in a place. And so we were able to find 4 neighborhoods in South Louisville that had put in their neighborhood plans that they wanted to see more greening in their neighborhood. So that was a good start. And we were able able to spend time with community leaders and elected officials. I believe one of them is on this call today when she was representing one of the districts in that area. And we sort of worked through a strategy for how do we talk about this work? I mean, our interests are in improving health. And so, we have nothing but good intentions. We are very proud to live in Louisville and very proud to have this as a signature project in Louisville. And we hope that the residents in the community also feel that kind of pride to be part of something which we hope will be groundbreaking and, historic in medicine. And so we did all the work that I think I just told you about, but it also included a lot of on-the-ground work, recruiting, key influencers in the community and really relying on their help to, to get the word out and to really learn about any concerns. Sort of just to be clear, to plant the amount of vegetation that we planted, while we did rely on public rights of way, we were interested in protecting the community from transportation-related air pollution. A lot of the planting did go into private property. And so, it really does require that extra level of outreach. We had clinical participants that we call clinical participants, and we had tree recipients, those that were recipients of trees that maybe didn't want to be in the clinical study. And it turns out both of those kinds of neighbors are really important to doing this work. And of course, businesses and a variety of other actors in the community that were on board with the project. So you'll see here, and I wish the Waterston Expressway was going right in the middle of all that, but it's not in this map. You can see we have a cluster design of essentially 8 clusters of treatment and 8 clusters of matched control area. So it's kind of a donut and it fans out. So the idea here is because we can't tell people where to live, we can't do a randomized design, but the next best approach is a matched control trial. So for the most part, these neighborhoods, socioeconomics, demographics, all that are roughly equal in these matched areas. And so that helps us get some confidence that, the effect is from the intervention. Okay, so before the project, we characterized the whole neighborhood, flew a small Cessna over and did LiDAR and hyperspectral scans that helped us understand how many trees and how much vegetation there was in place, how healthy that vegetation was. On the right, the green trees are healthy, the yellow trees are stressed, the red trees are dead. On the left is a speciation technology where you look at the reflectance from the leaves and you can map that to specific tree species. So of course we had to characterize the place first. We characterized all the air pollution. Big thanks to LG&E and AT&T for giving us pole access. We have 60 stationary air monitors. They've been there for 6 years now. It's a highly characterized air pollution environment in those neighborhoods. We then also ran a golf cart that had a very expensive piece of equipment in the back of it to test for volatile organic compounds. It's a very difficult chemical to detect, and it requires this very complicated equipment. And so, we had a graduate student from Washington University, I think, drive 3,000 miles in a 2-mile neighborhood over the course of the project to date. So you can see here the heat map of where the air pollution is. The important thing, of course, is that when it's time to do the intervention, we want to be planting in places that are hotspots for air pollution to maximize the effect. And so that was really important. And we also did some biodiversity work. So we, a partnership with Murray State University, had a team of ecology graduate students come up for 6 summers now, counting bugs, birds, and bats. And so we were able to characterize what the biodiversity looked like before and after the planting. And so that could give us some insights into how that might be a factor in health. Did a cardiovascular exam on everybody. So, to do this kind of work, you characterize the neighborhood, you recruit a cohort of volunteers. We're currently over 1,000, maybe 1,200 folks in the cohort, and in every wave of testing, it's between 500 and 700 people that are coming in for exam, and those exams are happening every 2 years in the neighborhood. In addition to cardiovascular workup, we do our best to try to keep track of other things that we know are important. So there's a handful of validated surveys for anxiety, depression, and stress, and social cohesion, and all sorts of other things, so that we can try to see how those aspects of health are being affected. Then you plant a bunch of stuff. Important to know, this is it's kind of a difficult topic in our community. If we were a tree planting group, we would be very thoughtful about planting trees that are highly likely to survive because they're very young and they're very small. But we didn't have the luxury for the scientific objectives of this project of starting with small, saplings or trees that a community resident could spade into the ground. We really needed instant green to do this. And so we brought in 30 and 40-foot trees from all over the country, 7 different states, shipping in 8,000-ish trees. We've had some very good coverage from the media, from the project, because it is so ambitious and so unusual to do work at this scale of this type. We did a lot of modeling of the neighborhood to try to understand how to plant. We know where on the hot spots and where the people lived and where the air pollution was, but the configuration of the planting is part of the science. And so are there optimal configurations? So we did a lot of fluid dynamic modeling to figure out what was the best way. We end up with this thing that we call a vegetative buffer, which is a tiered planting structure, which you can see in the lower slide here. If you just sort of plant trees wherever you want, it turns out it actually makes air pollution worse. And so the graph on the right will show you, what the current condition is without vegetation. And then you'll see that, no trees is the black line in there. The current condition has higher air pollution, so that's on the left. If we sort of reorganize the current condition to a design motif, if you will, we end up reducing air pollution. And the reason for that is air pollution, as it comes from its source, like a tailpipe, can get caught up in eddies inside of the spaces between things, and ironically concentrate air pollution. And we actually also discovered this with sound walls. So sound walls are great for sound. They're actually terrible for air pollution. And so all those models showed us that the sound wall will either roll the air pollution back into the roadway for the motorists to breathe, or dump it up over the wall and concentrate it into whatever the backyard is that might be adjacent to the sound wall, with much higher levels of air pollution there. So we think this modeling is an important part of guiding how to plant if you're trying to be health protective, which of course is our goal. Okay, so now we got lots of pictures of lots of big action. So here's sort of before planting, that's after planting, and that same sound wall. So you can see it was instant forest, right? All right, there is a video. I'm gonna try to skip it. I don't know. Can you hear this video? All right, we'll do it. Sorry about that. I'm not good with AV things. Video just started. All right. So hopefully that gives you a sense of the nature of the intervention, and I'll just sort of speed through to the punchline here. So we planted these 8,000 trees, and we did that over a 2-year period. And what do we get? Oh, and the mix of trees, people always ask these questions, what kinds of trees? Important to know, because greening in the literature is the effect that is most strongly associated with all the health benefits. We picked vegetation that is green as long as possible, and so those are going to be conifers, evergreen trees. They also have the best profile for removing air pollution because of their sticky needles that really are sort of brush-like and filter-like. We certainly did put some deciduous trees in, but lots of green. Okay, so the results, which we reported our first wave of results in July, August of this past year. We did find, to our surprise, that we saw a significant reduction in high sensitivity C-reactive protein, which is an inflammation marker. Let me sort of go back up to that. On average, about a 17% reduction. And it was not necessarily expected that we would see, let's call it an acute response from the planting a year or 2 years after planting. That made national news. That's something that we're sort of working through. Of course, it's a science experiment. We hope the effect will hold. And we're about to publish the comprehensive cardiovascular panel and try to move that into a high impact journal. The sort of one variable finding, and while it's interesting, I don't think it gives us the same kind of opportunity to share broadly in the field that bringing it all together will. So we're working on bringing the full cardiovascular and immunological panel together for that paper. The primary endpoint for this study is vascular stiffness in the carotid artery. And so, that's a slow process. We are hopeful that we will see that primary endpoint realized over the next 4 years, 5 years. The project was just renewed by NIH for another 5 years. It could be renewed again and again, and we could really look for the longer term benefits of the work. So we're very excited about that. We're very excited about working with other communities, expanding this work. You may know that we have a microforest that we're building in downtown Louisville, and we're looking at stress effects associated with that kind of planting. We're working with the Brent Spence Bridge project in Northern Kentucky to bring some of these planting designs into that project, which has a lot of community concern in Northern Kentucky, and it's the most expensive infrastructure project in the country. So we want to make sure that goes well and it improves health of people who live up there. And I'm here in Washington today because there's 7 other cities that want to do something like this, and we're trying to figure out how to do that because we need this to be a multi-site trial, not a single site trial. So we're looking for increasing the power of the evidence. And with that, I think I'm just slightly over time. Happy to take any questions.
Thank you so much for this presentation. I knew about the Green Heart Project through the School of Public Health, but I didn't know truly the impact and how much effort and all the involvement it demanded. So I'm really proud of your job, but to be Louisvillian and to have this project started in this city. And let's just hope and pray for, to be sustainable and to have a really long lasting positive effects on all our communities. And I'm so proud that this is going to go through different cities in the US, and just makes me think and just all the changes that are happening around the world. In Colombia, we're seeing, green projects going on, and the changes not only in health but in temperature within cities is also impactful. And the same is happening in Europe in different places. So we are in a good road, I hope, as Louisville, starting different things and different changes. So thank you so much, Dr. Smith. You're inspiring. We appreciate your job and the job of the team that is working alongside And with this, we open the floor for any questions or comments. Anybody? Ms. Margolis.
Thank you, Madam Chair. Has work you've done, given that it's largely privately funded, however, the research, as you mentioned, goes through NIH. It has been underway. How has the current proposed and instituted and legally challenged federal initiatives on the part of the Trump administration impacted, or has it not?
It's a great question. You're not the first person to ask that question to me in the last 48 hours. It's a big deal. I in no way want to minimize the situation that we're in as a country for biomedical research broadly. It's one of the leading industries of the United States, and so this is going to cause problems if this holds over time. I mean, we're good for, let's call it, the next year, but if this continues and this sticks, it will impact our ability to do the project beyond the next 5 years. I think we can get through this cycle. I think we can get through that okay. I mean, it won't be great, but I think we can get through it. I think it would be very difficult to continue the project if that federal funding was removed.
Okay. And I know that you work very closely with the Humana Foundation, because clearly this falls in our bailiwick as well. And I think what will happen as a reaction and response to this is that foundations and funders across the country are going to get multiple requests. And it's a question of prioritizing and collaborative partnerships. And you guys have done it really, really, really well.
Well, thank you for your help with that.
You are the varsity team. Thank you.
Thank you.
Thank you. Anybody else?
See Dr. Singhal and Deputy Mayor George.
Dr. Singhal? You're mute.
Hi, Dr. Smith. I have heard this so many times, and every time I hear it, I hear this pitch, I find encouraged. I find myself saying, man, this is just common sense. How come we don't do this everywhere anyways, right? And we talk about this. I just have one quick question.
Yeah.
You mentioned the sound barriers, the sound walls could actually be counterproductive when it comes to this particular work. And I do see that we're doing that quite a lot in Louisville right now. Is there a way to mitigate where we can have the sound walls, but also not create an unnecessary health condition in those neighborhoods?
Yeah, no, it's a great question, and I'm sorry I wasn't clear when I was explaining it. So we actually apply that greening filter right up against both sides of the sound wall, and that gets the community the sound reduction benefit of the sound wall, which is important. I mean, trees by themselves and bushes, they can reduce ambient sound, but they can't really take the loud sound out, right? So the walls are there; they're doing their job, but for the air pollution, that greening on both sides of the walls disables that eddying effect that we've seen, and it captures the particles. It slows them down as they age, they agglomerate, they become less dangerous. So it's a both and that's exactly why we're up in northern Kentucky, because the primary concern of that community is the sound of that interstate system, and it should be. It's loud. So working with KYTC, we're trying to also work on aesthetics and air pollution at the same time for those communities that are affected. Thank you.
Thank you. Deputy Mayor George?
Thank you, Chair. I just want to say, both as a neighbor and a participant, I think the large success from our perspective is just the level of strong community engagement that went along with this. Ted alluded to the advisory committee. I can just attest to the fact that Greenheart was represented for many years, even during COVID, when things were really difficult in the way of connections. They were present at all community events. They were present at neighborhood association meetings. And, I think, Ted did a good job describing the characteristics and the fabric of the neighborhood, but I will say that was really important because despite being more stable on some blocks, there's still a high level of mistrust. And so that level, I hope, will be continued and will be touted as part of the model city, because without it, I think projects need to be compromised. Thank you.
Let me just say thank you to you. And it's been so fun to watch your career while we've been evolving this project, because it's always been helpful and always been important. I think Inder, you said it well. This is the pitch. Between us all in this community, there were many challenges in this project. There continue to be many unintended lessons. And just for the sake of transparency, and Deputy Mayor has been an important partner, dealing with the houseless population, the maintenance issues associated with this kind of a project. I mean, it is not a fairy tale. We're also trying to figure out how to share those kinds of lessons. I mean, if other cities can say, well, that's great, this will be perfect. It's not perfect. And, we're, as scientists, I think we're trying to understand the social science of how do you change a neighborhood without attracting things that the neighborhood doesn't want. And, that's a part of learning these lessons. Urban, nature and urban settings comes with other things. And I appreciate everybody's patience on this shared learning journey, because the easier thing to do is just not plant stuff, right? I mean, if it's going to attract nuisance problems, let's just have concrete sound walls and grass. But I really appreciate being in a community where we can work constructively together as we learn these things.
Thank you. Thank you for both comments. Community engagement is fundamental, and thinking about, all the negatively effects of the research and keeping them in mind to improve it for the next stages. It's very appreciated. Anybody else?
I see Dean Cardarelli.
Dean Cardarelli, please.
Yes, thank you. First, I want to say thank you, Dr. Smith, for providing that terrific overview. I did want to just touch on the question that was offered earlier related to NIH funding. The impact of the reduction in indirect cost rate that universities are facing is highly detrimental to our ability to advance biomedical research in this country. The University of Louisville alone stands to lose somewhere between $20 and $25 million. And the reality is that we will not be able to continue the advances in cardiovascular disease and cancer and other important research that happens here. So I know our president and our executive vice president for research were in DC yesterday, talking to the Kentucky delegation. I will be in DC 2 weeks from today, along with all other deans of public health, advocating for re-examination of this order to reduce the rate. And then the last thing I will mention is that Dr. Smith and Dr. Batnagar and a number of us put in an application at the end of January, somewhere around $7 million, to advance the Green Heart Project and efforts related to the Green Heart Project. That was submitted to NIH, and we don't know what's going to happen, but I would just urge all of you as private citizens to feel free to reach out to your members of Congress to let them know that these actions are highly detrimental to our ability to keep up in research. Thank you.
Thank you, Dr. Cardarelli, and for your call of action. Please, everybody watching, let's keep on continuing with the research that is fundamental for the health of not only ourselves, but the whole community. Anybody else? With this, we just want to say thank you so much, Dr. Smith. What you're doing is really impactful, with lots of benefits, not only for this community, but we have seen your work with wastewater. Thank you so much, and we will keep you in mind. You will be part of our
happy to come back with
continuous
updates.
speakers.
And I'll bring the celebrities.
Thank you so much.
All right, we'll see you all. Thank you.
Appreciate it. Thank you so much. Appreciate it. And with this, we will continue our agenda and allow time and space for our updates and reports. For the mayor's office update, now I yield the floor to Deputy Mayor Nicole George.
Thank you, Chair. I have 3 updates, and I'm confident Dr. Single can provide details for anything I may share that needs more context. Want to say that the Metro Council is currently working on and has a proposal for the 3rd tranche of opioid settlement dollars that will include approximately 2.9 million that will go to things like Casey's Law to support treatment for Casey's Law, will go to support diversion for the unlawful camping docket, and will also go to support, the largest chunk, in fact, will go to support prevention through a partnership with JCPS. So that will be before budget Thursday, and we're looking forward to being able to execute those dollars out into the community fairly quickly. The second update, I know many of you guys were following happenings with the lead registry fairly closely. I want to give a big shout out to my public health colleagues as well as those in code enforcement. Despite, seeing the rollback with the lead registry, they are committed to working and moving forward and doing the very best we can with what we have, working and confident that we'll be able to increase outcomes for children and families impacted by lead. And then the third thing, of course, is that we are quickly approaching the budget season. So agencies have been, and that includes public health, working really closely with the mayor's office to work through budget requests. And obviously, mayor will give the budget address the 3rd week in April. Thank you.
Thank you very much, Deputy Mayor George. And now we go to the director's update. I now yield the floor to our Executive Director for Louisville Metropolitan Health and Wellness, Dr. Dersingle.
Thank you, Patricia, and thank you, board members. So in addition to what Deputy Mayor George mentioned, there are a couple of other things we're doing. The WIC program, as you heard from Jennifer Bowman, I think it was the last time or the time before, there are over 20,000 families in Louisville who qualify for WIC program. And we have captured around 13,000, and there's another community partner who usually able to capture about 3,000. So we have been brainstorming what is that we can do to help more who need help. So we try our new pilot at our LNN building. We will be extending hours for 3 months, and they will be from 7:30 in the morning till 6 p.m. Monday through Thursday. And after the end of those 3 months, we'll compile the data and we'll interview our staff members to see if we are able to capture more people. And then we'll try to not only make it permanent at that place, and we'll try to extend that at other locations. As you also heard from Connie 2 weeks ago, 2 months ago, we are moving towards the mobile immunization clinics. And from what we see for the last couple of months, we have made a very good decision. We are visiting different community partners. We have been to La Casita, Salvation Army, Americana, and the document that we sent you, there's a tab that you can click. So if any of you feel that there is a place that we should go to, there's a form that asks you certain questions that prepares us ahead of time. In addition to that, we are also working with other community partners to see where we can have our presence on regular basis. We're still working on those details. We'll let you know as we crystallize those. As far as our expansion of quick response team, I don't know how many of you really know about our QRT team. It's an extremely successful program, and they have been recognized many different places for the work that they do to reach out to people who have overdose um, and other concerns, mental health related concerns, where our team reaches these people at their homes within 72 hours of finding out. And they were even, I think, one of the news media did a video on them, and there's a um, link that you can click on and watch that video. It's pretty neat. What we have just done, we signed a memorandum of MOA with Norton's. So Norton will let us know when there is someone there with a overdose, and we'll try to reach them within 72 hours. You already heard from Deputy Mayor about the changes to the lead ordinance. I think this is probably the best we could think of, given um, the state was pushing down on us. And I think this is a good compromise. It still allows us to do what we need to do, not as robust as we would have liked to, but still um, a good compromise. On the avian flu, as you know, that's also among the birds. We know you have all heard millions um, affected. There are about 68 cases of H5 human cases as per CDC. There's none in Kentucky, and there's still no human to human transmission, as we know. And we are advising in Kentucky, we have some flocks that are infected, and we giving people guidance, and KDPH is in lead of that. As far as the flu and numbers and the COVID numbers for February, month of February, we had 1,956 confirmed COVID positive and over 8,000 flu, although for the last few weeks, we're seeing the trend going downwards. Any questions? Open to answer any questions if anyone has.
I've got a couple of questions, if I could. The mobile vaccination clinics, are they operating at kind of the non-traditional hours, or do we have the capability?
So yes, and yes, but I can give you more details. If you could let us know what those hours that you need, we can work around it.
Okay, I'm trying to think about how to better, for me to do a better job with the immunization advocacy committee, to kind of have some kind of like almost like standing information, so that we know what is happening, so that there then is the an ability to share this. Because I think that at least what I'm seeing is that we've got so many activities that are going on, but we haven't used, and I'll take that responsibility, I haven't done a good job in trying to capture that information and then push it out, so that we have that that level of communication, so different partners on the committee are able to feel better engaged, and then bring that level of synergy that I think we need. So I look forward to figuring out, again, how can I pull information, do a better job sharing it, identifying opportunities, because I sit here and I'm looking at Delanor's face, and I'm thinking all of the nurses that we have that are ready to help, and particularly when we're just using measles as our example, that we have vaccine hesitance issues, we have vaccine confidence issues. Dr. Eccles has been an amazing partner with our pharmacist partners. So we have this capacity, but I'm having trouble figuring out how to get arms around and amplify that. So, I don't know the best way to, and I'm just kind of throwing this out, but I look forward to trying to figure out again, how do we maybe reimagine what our processes have been to take advantage of some of these new approaches with the mobile clinics, take advantage of the trust that is present, that, you know, the general public keeps saying, we trust nurses. Well, how are we going to take advantage of that? How are we going to help our pharmacist partners who we have literally beaten to a pulp with immunization efforts? What is it that we need to do, especially in this time where we realize we are, you know, we have decreasing federal resources? And, you know, I'm a glass full kind of girl. So I'm thinking, wonderful, how do we take hold of this within our own community? Because, you know, like we've learned from our Japanese partners, the people that do the work know the work best. I feel like that in Louisville, we live here, we know the work best, we know our partners. We just have to figure out how to do the best jobs. And so
Yeah.
I'm more just using this
Yeah.
opportunity with all the leaders that are gathered here to say, how do we maybe reconvene and rethink, reimagine what we can do regarding immunization? And, you know, I'm a lifelong Louisvillian. I hope I'm here for a lot longer.
Yeah.
And I want to do the best work, you know, for my community.
I have a quick response to that. So the first thing, I'll connect you with Michael Schufranz, who is our lead project leader at Metro Health for mobile health. But I'm going to take a contrarian point of view in this panel because I know it will be. I think the reason we're struggling to solve this problem because we keep on going back to saying hesitancy is the reason for this not happening. I promise you, I have spent 2 years now working on this. It's not the hesitancy, it's the accessibility, accessibility, and
Absolutely.
accessibility. So if we continue to use the words hesitancy, that puts us on a track where we're trying to solve the problem of hesitancy versus when you say we have all these nurses and we know it's accessibility, then we will rethink, okay, how do we solve this problem? Okay, measles, right? Except for a very small percentage of Louisville community that is opposed to MMR, overwhelming majority of the Louisvillians are not against MMR. Yet you have 20 plus thousand students at JCPS who are not immunized, right? So that is an accessibility issue. So if we really want to solve this problem, let's work with JCPS, that's 100,000, that's 16% of your population. That's where MMR has to happen, right? And then keep on going upwards and see where are those pockets where there is accessibility or hesitancy and how can we solve that? I just wanted to throw that out there.
I completely agree with you, and I want to stand up and cheer, because if we don't have vaccine where the people are, when the people are there, and it is in conversation and collaboration with people they trust, we will not be successful. I completely agree. So I think, how do we figure out what are all of these pieces? And I think, you know, many times we give vague information. And let me use as an example. If you want a vaccine, contact your healthcare provider. Well, not every provider has the vaccine. Not every provider is doing that. Instead, I want to say, if you want a vaccine, here precisely is the information that you need. This is where it will be. This is who will be there. This is how you access it. And then we make sure that every individual can receive the vaccine, whether they have commercial insurance, Medicare, Medicaid, no insurance, if they need VFC, whatever. That, you know, if our community is truly important to us, we will figure this out and we will make this happen. I believe it is. I think that, you know, it is sometimes connecting all of these disparate systems, and just as you have described. So, you know, I guess I want to, you know, challenge the the group to say, what are those gaps and how do we help you then fill them? And I think there are people here, you know, certainly on this call, and I'm sure those that are maybe accessing this through social media will want to do that as well. So I'm with you. So let's go get them.
You
Thank you very
got it.
much, Dr.
Thank you.
Carrico. Thank you. Thank you very much, Dr. Singal.
Can I just add a comment here?
Yes, Dr.
So
Cardarelli.
So I totally agree. Accessibility is key. Helping individuals navigate to vaccines is critical. But I'm going to push back on the pushback just a little bit, Dr. Singal, because we have a paper that we're submitting this week based on data that we collected in Eastern Kentucky. I will point that out, 15 counties there, in which we found a fundamental lack of understanding about how vaccines work and what they do and what they don't do, right? So they don't prevent people from getting the flu, but they reduce severity of illness and reduce the risk of mortality. So I do think that it has to be a combination of these factors. And lastly, I will just mention that I also believe strongly in talking with Dr. Stack and another health department director just recently that we are entering an era in this country in which there will continue to be growing vaccine hesitancy. And so I think we have to include that as a factor for consideration. And we have to educate people about what vaccines are and how they work in order to underscore the importance of vaccination. Thanks.
Thank you very much, Dr. Cardarelli. And I completely understand the point of view. And we need to explain, you know, in very basic language, what is an immunization and what they do. And of course, you know, they are not your shield against disease. And we have 3 questions from Marta Sanchez from Gilda's Club. Are mobile immunization clinics funded by the state? Dr. Singal?
You know, I don't know the answer right off the back. I can find that out. I think what we have been doing, if people have Medicaid, that we have been trying to build that. But if people have no insurance, then yes, then we cover it. But I can get you more details. I can get more details to everyone. And then you have a question, doesn't English only initiatives, well, language access be available? Yes, we're working on that. Is there a fee or health insurance needed? There is not a direct cost to the person who's getting immunization, but I will get these questions answered in a more cohesive way and send it to the whole board.
Thank you, Dr. Singal. If
Thank
there are
you.
no more questions for Dr. Singal, we will continue with family health centers. Now I yield the floor to Dr. Bart Irwin.
Yes, thank you. I would like to give you a quick snapshot of indigent primary care. This is data for 2024 from Family Health Centers. Family Health Centers served nearly 40,000 individuals over the last year. About a quarter of those were children, 17 and under. We had about 2,800 patient increase in limited English proficiency patients. About 4,000 were homeless. 25% were uninsured, and 32% were Black, 55% were white. More came from zip code 40214 than any other zip code, which is ground zero for the Green Heart study. So I found that interesting. Top diagnoses: obesity, this probably won't surprise you, hypertension, diabetes, and depression. And we're seeing some trends. We're seeing a drop in Medicaid patients. As a matter of fact, about 75,000 Medicaid recipients in Jefferson County lost their coverage since April at the end of the public health emergency. I was in Washington a few weeks ago and stated that number to Rand Paul, and he was pretty surprised that Medicaid numbers in Kentucky overall were decreasing. They are quite a bit. And Doris may mention this, in June, the re-enrollment, recertification for children began, so we expect some children to lose coverage at that time too as well. So that's a brief update.
Thank you so much, Dr. Irwin. For JCPS, now I yield the floor to Dr. Eva Stone. Dr. Stone, are you here?
I think Doris may have a report on Medicaid, somewhat more extensive.
Yes, okay. I will go now from the healthcare coverage and outreach. Now I yield the floor to Ms. Doris Basuchur-Fermin, reporting on behalf of Ms. Ashley Shoemaker on maternity leave. Ms. Fermin.
Hi, yes, good morning. So yes, in regards to Medicaid, all of the outreach and enrollment sites have had their debrief sessions with KHBE where they were able to give feedback to them so everything went well, provided improvements and also takeaways from that meeting. So outreach and enrollment offices also are losing federal funding from the federal grant. So we are basically just waiting to see what we need to do in regards to our patients and helping the clients in the community getting insurance, since we will possibly have different sites losing funding and closing such. So also we will be discussing the different bills that are due for Medicaid and that will affect Medicaid coverage. So we're just keeping an eye on those to see what the outcomes are and to see what our next steps will be. And like Dr. Irwin said, in regards to the Medicaid and children getting their coverage renewed, we do anticipate a lot of them losing their coverage, and hopefully we'll be able to find other avenues and things, different types of coverage for them, hopefully the qualified health plan and such. And our next meeting is April 14th at 4 p.m.
Thank you. Thank you very much, Ms. Fermin. And all this losing of budgets, it's hitting everybody. I'm sorry. We hope that this will get better, but it would get worse for a little bit. I'm sorry. For Greater Louisville Medical Society.
I had
Yes?
a quick question. Sorry, this is Dr. Shah.
Yes.
Do we have a sense of, obviously we know, hey, how many folks are going to lose or potentially lose? Do we have a sense of what is in store, or how many of these folks will we be able to cover with other opportunities? Because that is an important question, right? I mean, because otherwise we're going to see folks in the ER in other places. And we just talked about issues with accessibility, with not being able to get vaccines and things like that. So I don't know if there was sort of a plan or some sort of a guidance of how we're going to take care of such a massive number of folks in the city.
Yeah, I can speak to that somewhat. We found at Family Health Centers, Doris and her team, outreach enrollment team, have been very successful enrolling eligible persons into the state plans. So that's one thing. We've seen our percent of commercial insurance increase because of that. Beyond that, what's going to happen with Medicaid, of course, we're all waiting to see. My guess is probably work requirements or block granting. I don't know if there will be outright cuts. We'll just have to wait and see. And Family Health Centers will serve persons regardless of their ability to pay. So that's one resource.
Thank you, Dr.
Yeah, Dr. Shah is at the emergency room, so that was the reasoning for his question. Thank you, Dr. Shah. Ms. Margolis?
Yes, I just wanted to add to the comment that the Dr. Irwin and Shaw made. The Kentucky workforce, or the Kentucky workforce, the state through the exchange will cover some of those folks. And there is extra monies that have been given to Jefferson County. And so there are some contact people. So if there are issues, I am happy to assist, and just let me know.
Yeah, thank you.
Because it's a large number.
Thank you, Ms.
But
Margolis.
a number of them have gotten on the exchange.
That is good to know.
Through managed Medicaid private sector plans who contract with the government. and those currently have not been interrupted.
Okay,
Okay.
thank you.
Thank you.
I think you're muted. I think you were
I'm
muted.
sorry. Thank you so much. Greater Louisville Medical Society. Thank you, Dr. Batia. I yield the floor to you. Appreciate it.
Thank you, Madam Chair. Thank you very much. I have just a couple of things to report. I'm sorry, this printer started working same time that I'm starting to report. But basically, a couple things. Our president has been invited to speak at the Black Family Wellness Spa on 15th of March on social determinants of health. And that is what he's going to be doing there, offering, free screening, blood pressure, eye vision, etc. The usual. I don't know if they're doing any vascular screening at that point or not, but he's invited, and I thought it might be a good opportunity for him to also address immunization there at that wellness spa, that he's going to have a major audience there. The other thing is that we are going to have our doctor's ball on the 8th of March, where GLMS has this at the Geens Foundation Center. And that is going to be the big time where we showcase what GLMS has done for the community throughout the year and for the physicians as well. And then we also have reward the nominees for various outstanding awards that they get from each facility. So there is one from UL Health, there'll be someone from Baptist, and then again from Norton's. And then there's the Paragon Award and the award to the physician for outstanding service in the community. So I will report to you about the results of that. I do know them, but it'd be nice to wait till the end of that banquet ball that we have. And that's it for now. Thank you.
Thank you very much, Dr. Batia.
You're welcome.
Now for the Kentucky Nurses Association, I yield the floor to Ms. Delano Manson.
Good morning. Can you hear me? Yes. We have been very busy monitoring legislation that will impact the nursing profession and healthcare. As you well know, there's well over 1,000 bills, and we have been monitoring 200 of those, with the bill on lead being one of those. I just recently attended summit in Washington, D.C. with the American Nurses Association that focused on how do we continue our focus on diversity, equity, and inclusion so that we can get individuals in our profession of healthcare that actually look like the patients and the families that we serve. And then also focusing on how do we retain those individuals. Then how do we continue with categorizing who we're treating and the disease processes that they have based on their ethnicity and other disabilities. And so we are continuing with the work to focus on diversity, equity, and inclusion. And I really would like to have that in the record. Thank you.
Thank you very much, Ms. Manson. Do we have a representative for Greater Louisville, Inc.? I didn't see Ms. Summerwell on our list. Okay. Now we will continue with our committee reports. For Immunizations Advocacy Committee, Dr. Carrico, do you have anything to add?
No, I think, yeah, for time, let's move on. And yeah.
Thank you very much. And I think if there is any old business, you can share it now. Any new business? If not, thank you very much for taking your time and to participate with us at this month's meeting. The next meeting will be held on Wednesday, April 2nd, 2025 at 8 a.m. This will be a virtual meeting. If there is no further business, this meeting is officially adjourned. Thank you very much.
Thanks, everyone.
Have a beautiful day. Thank you very much.